Hi, everyone. I'm Breza, a fourth-year graduate student in Richard Price's lab at the University of Virginia. And today I'm going to be discussing combination therapy for glioblastoma. Glioblastoma is the most commonly diagnosed brain tumor and is characterized by heterogeneous leaky vessels, as well as highly invasive tumor cells. Current standard of care therapy for GBM includes surgical resection, radiation, as well as temozolomide chemotherapy. Despite these interventions, the mean survival time for patients is less than 16 months. There are several challenges to delivering therapies to GBM due to its invasive nature, such as highly infiltrative and unresectable tumor cells that invade surrounding tissue and remain there even after surgical resection. Additionally, the highly regulated and impermeable blood-brain barrier, which prevents large particles from crossing from the blood into the brain tissue and the infiltrating margins of the tumor, acts as another challenge to overcome. Additionally, the blood-tumor barrier, which is characterized by leaky and poorly formed blood vessels within the tumor bulk, decreases the pressure gradient across the vessels, impacting mass transport from the bloodstream to the tumor tissue. Overall, this creates a microenvironment that impairs drug delivery. This is especially apparent in the delivery of large molecular weight immunotherapies, such as monoclonal antibodies, that have low penetrance across the blood-brain and blood-tumor barriers, limiting their therapeutic effects. Within the context of my project, we aim to address these challenges to immunotherapy delivery using magnetic resonance image-guided focused ultrasound blood-brain barrier opening, which can be leveraged to enhance the delivery of immunotherapies. For this presentation, I will focus on the delivery of an innate immune checkpoint inhibitor, a monoclonal antibody called anti-CD47. To give some background on CD47 as a therapeutic target, CD47 is a cell surface glycoprotein that is ubiquitously overexpressed on GBM cells and has been identified as an innate immune checkpoint. It allows tumor cells to evade immune detection via its binding interaction with signal regulatory protein alpha, or SIRP alpha, on professional phagocytic cells such as dendritic cells, macrophages, and microglia. Binding of SIRP alpha subsequently inhibits phagocytosis. As such, CD47 acts as a don't eat me signal. Importantly, CD47 is not appreciably expressed on normal cells, making it a cancer cell-specific protein target. Both clinically and preclinically, efforts have been made to use an anti-CD47 monoclonal antibody to block the CD47 SIRP alpha immune checkpoint. Studies have shown that this blockade can increase phagocytosis by eliminating the don't eat me signal and has been employed in other types of cancers. However, as I stated previously, there are additional challenges to effective antibody therapy to brain tumors. A recent study from our lab employed the use of PET imaging techniques and radio-labeled CD47 monoclonal antibodies to determine if MRgFUS can potentiate the delivery of anti-CD47. This study found that FUS increased antibody accumulation within the tumor and enhanced tumor control through decreasing tumor growth as well as increasing survival. And while this combination has significant increases in tumor control, we did not see evidence of an adaptive immune response, which leads to the question, how can we set the stage for a sustained immune response against GBM by bridging the innate response induced by anti-CD47 therapy to adaptive immunity? One way we can do this is through the use of the standard of care therapeutic temozolomide to increase eat-me signals on tumor cell surfaces. TMZ is a DNA alkylating agent that induces eventual apoptosis by causing DNA damage. This damage results in the translocation of prophagocytic cell stress marker calreticulin to the cell surface. Calreticulin is an eat me signal that has been suggested as a counterbalance to CD47's don't eat me signal. This suggests that chemotherapy can prime the tumor for immune detection via upregulating cell stress signals. By combining CD47 blockade with chemotherapy treatment, we can reduce CD47's don't eat me signal on the tumor cells and shift the balance towards an anti-tumor immune response, such that we're not only taking off the brakes, but also hitting the gas towards increasing phagocytosis. As such, the goal of my project is to combine MR-guided FUS enhanced delivery of anti-CD47 with TMZ to promote an improved survival and tumor control while inducing an adaptive anti-tumor immune response, where we expect to see a decrease in tumor size and an increase in survival due to the combined therapy. So in designing these experiments, I wanted to keep in mind the staging of cell stress signals with CD47 SERP alpha blockade, while also minimizing the dose of chemotherapy, as TMZ can have immune suppressive effects. As such, I created a framework to treat mice with a total of 5 TMZ doses prior to repeat MRgFUS blood-brain barrier opening delivery of anti-CD47. I then monitored mice with serial MRI. I found that TMZ and CD47 significantly increased tumor growth control and extended survival both with and without FUS. These results suggest that the response is likely driven by TMZ rather than a combined effect. For this presentation, I'm going to discuss 2 mice that had unique responses to therapy and did not follow the treatment trends within their groups. I will also discuss how these unique response patterns can better help understand how to proceed within this framework. To give context of how the tumor typically progresses, here I'm highlighting a representative untreated control mouse where the tumor is denoted with a yellow arrow. I would next like to highlight a mouse within the TMZ plus anti-CD47 with no FUS group that, unlike the other mice within its group, had a unique response to the combination therapy. As you can see, on day 10, the tumor is fairly small. And by day 14, the tumor is not visible by MRI, which is when the anti-CD47 treatment begins. As such, this mouse's tumor regression is likely due to the cytotoxic effects of TMZ alone. This result emphasizes that to better leverage our FUS immunotherapy combination, we need to first understand how temozolomide administration modulated tumor growth and survival, which leads to the question, does tumor size and administration time impact TMZ-mediated tumor control? To answer this question, I staged the administration of TMZ monotherapy, starting either day 11, 14, or 17 post-tumor inoculation, with day 11 representing the original treatment start day of the previous study I just showed. I found that regardless of when treatment was initiated, tumor growth control and survival were significantly increased without complete tumor regression, suggesting that within this framework, tumor size and its related treatment start time is not a significant factor to consider. Going back to that initial study, I want to highlight the other unique responder mouse that was in the TMZ plus CD47 with FUS group. Unlike the previous mouse, this mouse had a unique pattern of tumor regression. As you can see, the tumor continued to grow even past the cessation of treatment. However, on day 48, the tumor was no longer visible by MRI. This late regression of the FUS-treated tumor is consistent with the generation of a systemic anti-tumor immune response. Further, the FUS-treated tumor reoccurred, which suggests the acquisition of an adaptive resistance mechanism. And while this result is exciting, the question is, why did only one mouse have this response? One possible reason is a common side effect of chemotherapy, which includes immune cell depletion. So we next asked, how do these therapies impact the peripheral immune response? As such, in another cohort of mice, I did a complete blood count assay to determine changes in circulating immune cells. I found that 3 days after the cessation of treatment, there was a decrease in white blood cells across all treatment groups, indicating these mice have a common chemotherapy side effect, leukopenia. Additionally, of these white blood cells, the vast majority were lymphocytes, which includes our T cells. And we similarly saw a significant depletion of circulating lymphocytes, suggesting lymphopenia. This result suggests that perhaps even at the low dose of TMZ, this framework might be depleting peripheral immune cells that we're trying to recruit to drive an immune response. In conclusion, I've established a framework to combine standard of care chemotherapeutic TMZ with MRgFUS blood-brain barrier opening delivery of anti-CD47. And within this framework, the combination of chemo and immunotherapy significantly increased survival and growth control with and without FUS. Several serial MRI revealed unique treatment responses that led us to look at the impact of TMZ administration timing and how TMZ administration impacts circulating immune cells. Future directions will include using techniques such as flow cytometry, as well as multiplex immunohistochemistry to assess systemic and tumor immune microenvironments to better understand how to modulate this current framework. And with that, I'd like to thank my lab, as well as our key collaborators, as well as our funding sources. Thank you.